What's happening? A cakes conference with us, Jen Haas, Tracy Zundel. All right, so just to set it up, the case, here's what's posted. It's a bronch. They're going to do an ultrasound with it. The patient's got mediastinal lymphadenopathy. They're going to try to figure out what is causing this, and they want a general anesthetic. So the next question is, for one of our seniors, what do you want to do for this case? Initially, just on that posting, what anesthetic do you want to do? And got him. All right, Adam, yours is the first name we see. Pegorinsky, Chief, show us what it's at.
Can you hear me?
Uh-oh.
Can you hear me?
Adam, are you available?
I can hear Adam. Can you guys hear him speaking?
Hello? Can you hear me?
Oh, Mark Zundel.
Well, if somebody can say
Dr.
ProProc2.
Zundel, you're next.
Yeah, we can hear Adam.
Oh, sorry. I had us muted.
Yeah, we can hear Adam.
That's just me being a jerk. Everyone knows that. All right, so back to Dr. Wanzel.
No, Pegorinsky.
Pegorinsky. All right, sorry.
Well, first I want to look at the CT and make sure he doesn't have some raging mediastinal mass, but if everything looks okay and there's no other serious comorbidities, ProProc tube.
ProProc tube. Okay, and then are you, so you've got the tube in. Anything else important to know up front?
Apart from like all of his other medical history?
No, just like anything else special for the anesthetic. You can say no and we'll move on.
Not that I can think of right now.
All right, cool. So then next, so you wanted to know their comorbidities. Here's what we've got. 67-year-old female, cabbage, and then all the other great things that we typically see for our patients here. So then the next question is for one of our, let's go with a CA1 here, and volunteer, please. What is this ASA?
Dr. Richards.
Ooh.
Let's go with this. What would you give this patient as an ASA score?
Sorry. You said status post cavity.
Yeah, here's the list of everything.
Oh, a very clear ASA class 3.
Okay. So then, what is the difference between a 3 and a 4? Any takers? Let's see here. How about Dr. Spittler?
A 4 has more diseases that are like had problems recently or not well controlled. Like they had a heart attack like 30 days ago or something like that, and had a cabbage like 30 days ago.
Is 30 days the threshold that we use for that?
Well, it depends on is it 90 days?
All right. No, that's the whole point. Don't worry. Speak up. It's okay to not be sure. So go to the next. Actually, in doing this, what I found out was that the ASA actually updated their current definitions December of last year, just almost on the 1-year anniversary. And so to your point, Dr. Spittler, it's a 3-month threshold for MI, stroke, stents put in, etc., that define a 3 or a 4, and then some other things as well. But interestingly, if we kind of go on, they also finally added examples for peds. So, you know, when you're doing these pediatric patients who have a AHI of 89 and they're getting the tonsils out, by definition of the ASA, they are a ASA 3. And there's other things, won't kind of go through them, but just a FYI, they exist. And in OB, they gave examples as well. There is no such thing as a pregnant ASA1. Normal pregnancy is a 2. And what they said is it's not pregnancy isn't a disease state, but there's such major physiologic changes that it's a change. So everyone who taught us that a pregnant woman's an ASA2, it is now written in stone. So just a reviewer on that. So then we kind of go through.
Can I just say a couple things? Yeah. So the one thing I want to point out as well, they did put out these 3 different categorizations for healthy adults, or for adults, for pediatrics, and for pregnant patients. The actual definitions stay the same between the 3, or between the 3 different categories. So an ASA1 is a normal healthy patient. ASA2 has mild systemic disease. ASA3 has severe systemic disease. And then the one I really want to emphasize here, because we work at Frederick Hospital, a patient with severe systemic disease that is a constant threat to life. That doesn't have to mean every day of their life. That can mean while they are here in the hospital, they have a disease that is life-threatening. Even if the chance to end their life is low, any sort of sepsis, any sort of shock, any sort of hemodynamic instability qualifies as an ASA4. And I want you to be thinking about that and thinking about your recent cases when we review the next slide.
Yep. All right. So we talk to the patient, and this is what she tells us. Everything red is the stuff that we got, not from the chart, but from talking to her. So then, Dr. Foster, what would you classify this patient as an ASA now, and why?
I would classify her as an ASA4. She currently has stable angina, so she, despite having the cabbage, could have an MI, especially going under general anesthesia. She has OSA and not on CPAP, so that's another reason why with her body habitus, I'd be concerned for her, for that to be a constant threat to life too.
Yeah, I think you nailed it on the head with the angina. That's a sign of ischemia. And I mean, that's textbook on one of the examples that they gave. So, all right, so ASA4, we talked about that. So why does it matter? Can anyone, let's see here, tell us why having the right ASA class matters? Oh yeah, Dr. Zundel.
We're getting you for real this time, Mark. Uh-oh.
I punked him once and now he just ignores. Yeah.
We could go with Dr. Ali. I know he's paying attention. He gave us a comment.
All right.
Dr. Ali, you want to comment on ASA status and why we care?
It gives you information about what their risks are perioperatively.
Yes.
Hello. Yeah. Sorry to interrupt. I was having difficulty with my speaker.
Oh, hi, Mark.
Hey.
Welcome.
Hey. So ASA status gives you that ability to just prepare ahead of time and focus on what difficulties you might have, and so you can just be prepared and have a higher level of acuity to focus on the patient.
Nice. So we've got, so Dr. Ali mentioned, so you guys have covered the 3 different things. So Dr. Zundel, you talked about the acuity of the case and how that affects us mentally and how we tend to prepare for perhaps a little bit more thoroughly, a little bit more carefully if our patients are sick, which is appropriate. Dr. Foster just put in the chat that there's a function with billing purposes. That's true. We're going to cover that in just a minute. So ASA status affects our billing, and we'll talk about that. And then the last one, Dr. Ali mentioned that, or Dr. Hamyari, I'm sorry, Ali. Dr. Hamyari mentioned that it affects perioperative complications. And that's, I would argue, the biggest difference in the ASA score and the biggest reason that we track it, because it's very, very predictive of that. And we're going to cover that in just a minute. So good job, team. You guys covered it all.
Yeah. So you can hit 3 times. So just a quick review of some publications. These were all from surgery journals, and they were done by surgeons, and they say, hey, look, if the anesthesiologist puts an ASA score, it predicts very well what our outcomes are going to be. So it matters because it goes to risks of complications.
That's something that the surgeons follow very closely, right? They're always playing the game of what their outcomes are going to be like if they do this case, if they don't do this case. And so we are not the only ones, and the billing people are not the only ones that pay attention to this score.
Mm-hmm.
So this is put out by the ASA. This is a graph of complications by ASA status. Now, these are broken up by different surgical specialties. So it goes from gen surg, gynecology, neurosurg, ortho. And I'm not going to go line by line because the lines essentially all have the exact same trajectory. And it's a broad line, but what you can see is anybody who's an ASA 2 has a complication rate less than 10% across all specialties. So even the highest risk specialties, which is ortho there, and I assume that, if you're an ASA 2 and you're having an ortho surgery, it's a big thing versus ENT, which is the lowest. If you need sinus surgery and you're healthy, complication rates are low, but all of them have less than 10%. And when you go from a 2 to a 3, what you can see is now you're basically at 10 to 20%. And so the overall risk for complications doubles in going from a 2 to a 3. And if you look at going from a 3 to a 4, if you trace this out here, now you're suddenly roughly between 20 and 40%. So you've doubled it again. So the predictive factor of this score, which is just the anesthesiologist looking at someone and saying, according to this very broad classification, these guys are a 2, this person's a 3. I mean, if you think about it, this is remarkable because it's predictive across multiple specialties, and it's more than us eyeballing it, but it's us doing the exact same preoperative evaluation we would always do and then putting a single numerical digit on it. Think about this in terms of how complicated the predictive calculators get for some things. The ASA score is brilliantly awesome scientifically. And the other thing is when we are doing quality for our hospital, when people go back and they review our complication rate, if we're undercalling our ASA scores, what that means is that our complication rates look like they are double what they should be for patients that have been undercalled. So the people that are actually 4s that we call 3s, they're going to have a lot more complications than the people that are actually 3s. And then that makes us look like we have makes us look like we're doing bad work, really, when people review the hospital. So all of this, and Dr. Lauer chimes in, it also triages SSI as well as sentinel events. Exactly. So it's a big factor in how we do our internal evaluations as well. And Kathy, do you want to comment on that a little bit more and expound on that for the residents?
Yeah, I had to get off of it. Can you hear me?
Yeah, we can.
Okay, so how we report surgical site infections, it gets sent to, I'm forgetting the acronym of the center, but the only thing that triages whether patients are at risk right now for a couple, NHSN, that's the name of it, is our ASA score. So it really behooves us to be accurate with that. I'm not saying to upgrade people, but the other thing I would also mention is that death in an ASA 1 or 2 is a sentinel event, just like retained foreign object or any other kind of thing that happens that's bad. So it's really, I'm so thankful that you guys are highlighting this. I can tell you, over the years, I've seen so many crazy things. Somebody who's intubated in the ICU on pressors, and somebody writes them as a 3, because I think we have this tendency to default to 3, which, when I bring this up with the provider, they said, well, they were weaning, and, so we have to be accurate. So call the 4s, or the 5s, because it really does have an impact on our organization.
Yeah, that's exactly what we were going for here. I think, just as a last point, there's a tendency, at least there was for me in residency, I felt guilty when I was, maybe making a call that I wasn't totally sure was a 3 or a 4, and I tended to downgrade, or maybe by the book, they're clearly a 4, but I just know the case isn't going to be that hard, so I don't want to overbill anybody, so I'm going to put a 3. All of that goes out the window when you realize what these scores are used for and the appropriateness of having them accurately classified. It's not based on how you feel as an anesthesia provider.
No, and that brings up a great point that we'll touch base in just a sec, is what is the impact on billing as well. So for anyone who's rotated in pre-op clinic, this is one of those calculators that they did a study on. The American College of Surgery has a giant database, and we can query it. So you put in the procedure, you put in patient's information, and it spits out all of this wonderful risk that's personalized approximately to that patient. And you can see for this 64-year-old guy who's an ASA3, BMI 26, who is on oral diabetes meds and takes lisinopril, this was a risk for a Whipple. And these are the risks that then the results and the complications for that patient are compared against. And you can see on here that surgical site infection is there, cardiac complications, all of these things. And one of the biggest things that changes where these lines are is ASA status. So for our colleagues who don't work in pre-op clinic, I just wanted to show this. And you know, we put this in a lot of those pre-op notes. And if you're ever curious as what the risks are, this is where you can find it. It's free to use. So, yeah. All right. And then we got the data. This is the actual ASA class for anesthetics done at Froedtert in the last 6 months. So there's approximately 33,000 records that were queried, and this is the distribution of ASA status. And Dr. Zundel and I were talking and said, does this seem about right based on the patients that we see? Who's got thoughts on that? Let's see. Dr. Vickery, does this kind of match up with your experience?
About 10% of your patients are fours, according to this.
I would say I probably haven't seen as many fours, or I've been under putting them, like you guys said. But I think based on kind of how I've been doing it, I would say most of my cases have been ASA 3s recently.
Okay.
Yeah, that's fair. And I think, you know, it's obviously very difficult. We didn't do 33,000 chart reviews for this to actually classify the ASA scores. We just looked at this and said, by the way, thank you, Dr. Lauer, for this data. We really appreciate it. Yeah, so Dr. Spittler says, who's getting all these twos, right? And
well, don't forget, these are also people at the Eye Institute, people down in GI getting their screening colonoscopies. But even still, maybe there's a little skew because we see so many sick people. That's what this is just trying to show us.
Yeah, we suspected, as I think many of you are getting at, that we undercall our ASA 4s at least. You know, 2s to 3s and 3s to 4s, we're probably undercalling that relatively consistently as we were looking at this data. So that's the take home for us as a group, is be mindful. We want to make sure we're getting the credit for the work we're doing, and we want to make sure that we're making the hospital look as, you know, we want to make sure we're appropriately representing the risk factors for these patients so that the hospital's care looks as good as it actually is.
Okay.
And anybody else have any comments here? Anybody want to chime in before we move on? This is our systems-based practice part of this. All right.
Well, sorry, this is one thing that I actually was just kind of thinking was, I feel like when I'm on wraps now, so I kind of see the pre-ops that people have like started the day before and kind of skim through it and see like what the patient's medical problems are. I feel like sometimes when we're pre-oping patients to take to the OR ourselves, maybe we get really deep into it and we say, oh, he has hypertension, but like it's not that bad, and like he's been working on it, or his A1C has like been getting better, things like that, to kind of make ourselves feel better about some of their medical problems. Whereas now I feel like I'll skim it. I'll say, oh, he has this, and this. Oh, I wonder like why did they put him as an ASA3? Like I would think he was sicker than that, just from getting like the broad overview.
Exactly. So, and then to Adam's point, comments on the unreliability and consistency.
That's a good question. That's one we didn't delve into, Adam. That's a really good question. So Adam, Dr. Pagorzinski asks, do we have any comments on the unreliability or inconsistency between providers with ASA scores? And I think, you know, we're kind of demonstrating that in the chat. So my understanding is it's relatively consistent if people follow the rules on it. Obviously, if we aren't following the guidelines and we aren't doing it properly, it will be less consistent. But that's off the top of my head from deep memory, and I believe it is very inconsistent between providers that have that are actually using the score appropriately. As far as cancer and ASA, I believe. So, Dr. Boxhorn, I'm not an expert. If you want to comment on that, I know you work in pre-op clinic. You're welcome to. My answer would be most people with systemic cancer are going to be ASA4s. In fact, virtually everyone with systemic cancer is an ASA4.
Yeah, hi. Yeah, this is something that's always up for debate. Yeah, if it's a systemic cancer, certainly an ASA4. But I think one could argue that if it's like a very localized lesion that has no systemic effects at the moment, that you could call them an ASA 2 even, or an ASA 3. And I think this is one area where there's a lot of variability between providers. And I've tried looking this up too. I haven't found anything to really specifically focus on cancer and how that affects the ASA classification. But I've just noticed that different providers do different things, like whether, you know, everyone's an ASA4 with cancer, or you know, I think it just really depends. So I was just wondering if anyone else had any more insight into that.
I'm aware of no hard rules, but I would default to what it comes down to in the ASA status and say if it's systemic disease, then that's clear, but otherwise difficult. Adam, I don't even know.
Okay, so the question was, what would you give an otherwise healthy patient who has depression and is actively suicidal? What I can say is not an ASA1. I have no idea.
Yeah, so you could argue a 4. I think that's your point, is you could argue a 4, and I think I would probably in my head very unscientifically weigh the credibility of the threat. Dr. Carey asked, does the E designation for emergent have implications for billing or complication rates? I know it does for complication rates. I am not sure if the implications exist for billing, to be frank. These are great questions.
Yeah. And then if just to kind of go, because you talked about billing. So I didn't look at the E, but this is published by the ASA, and we have a modifier for ASA class. And really what it goes down to, 3s, 4s, and 5s actually do bill slightly different. And the billing is 1 unit, which is equal to typically 15 minutes of anesthesia time. So it's not that much. And I'm going to have a little thought exercise for you. And it is, if we do 60,000 cases a year and we misclassify 10% of them, and a unit is $50, which is a pretty decent blended unit, how much revenue have we lost? So by changing someone from a 2 to a 3 appropriately, it's $50. That's not hundreds of dollars. So the amount of revenue lost is $300,000. Now, if you're in private practice, that's the ability to take vacations or have additional equipment. Here, it's who knows what, but this is something that we're already doing the work for. Just pay attention that this impacts your bottom line and overall your ability to provide care to your patients in some manner. So that's that.
We're going to move on from that. So our concerns for this case, we've got some more residents to pick on. Dr. Jensen, I see you're here. Anything else you want to know about this patient, and what do you want to do for her physical exam?
So I'd want to make sure to listen to heart and lungs for physical exam. The history is pretty well covered. I think I would just want to make sure to know if she had had any previous complications with anesthetics, and if she's been regularly taking medications or following up appropriately. But other than that, I'm pretty satisfied.
No problems with anesthesia in the past, follows up with all of her appointments, is very engaged in the health system, and then her physical exam was completely benign except for a Mallampati 3 and there were high-pitched inspiratory sounds on the left.
All right. Gonna move on here. So let's see. We need anyone want to talk about your anesthetic plan now? Dr. Kyle Murray, any changes to your plan based on this information?
Apologies, I was struggling with the unmute button. So did you say she was a Malapite 3?
Yep.
Okay, so I think as far as the physical exam, it gives me some implications for her potential airway. I think that would make it maybe a little bit more challenging, so that might make me consider doing something as far as doing upfront video laryngoscopy, or even something like at least consider awake fiber optic.
Okay, that's fair. Be ready for anything, right?
Kian, so someone had said ProProc 2. Are you still on board with that general plan?
Yes, but I'd also
Okay.
have phenylephrine available. Did we ask what her functional status is, and do we have like
Yeah,
a echo,
she's active. She gets some dyspnea on exertion. That was on there. 5.5 mets on an exercise test.
okay? And
Alright,
does she have a TTE? Like what's her EF?
EF's 57%.
57. Okay, I think ProProc tube's okay, but go light on the probe and also have phenylephrine available.
Okay, so the
ready to go.
tube's in. How do you want to maintain anesthesia?
With her, like to maintain anesthesia with sevoflurane.
Is that going to work in a bronchoscopy?
Not necessarily. I've done it with sevoflurane before. Is it a rigid bronchoscopy?
No.
Flexible. Okay, in that case, run a propofol infusion. Have some remifentanil as well, so you can run less propofol. It's more cardiac stable that way.
Okay. What ventilation mode are you going to use?
I'm gonna hand ventilate.
The entire time?
Yeah. And
Okay.
if I need to go away from it, I can put it onto volume control or pressure control for when I need my hands. But when I've done bronchoscopies in the past, I like to hand ventilate because I like the feel of what's going on, and I can change the pressures depending on what type of tidal volumes I'm getting and what they're doing. Because if they cap it and you're on a pressure control mode, you're going to get a huge tidal volume, or if they cap it and you're on a volume control mode, you're going to get a huge pressure, and that could be detrimental to the lungs.
Cool.
There.
I like it.
Yeah, I like that too.
All right. So then, just a quick show. They chose to do propofol and remifentanil. They chose pressure control, and vitals stayed pretty all right. Just some phenylephrine bumps. So that's the case reversed with neoglyco. So to PACU. And this is where the rest of the case comes in. So patient rolls in, and before they even get into their bay, you can tell that you're the PACU resident, they're agitated and they're having difficulty breathing. Get the vitals, and they're hypertensive, they're tachy, their sats are low. Let's see here.
So Kevin, I assume that's Kevin Bites. What are your thoughts about this?
I don't like that this person is relatively hypoxemic compared to where they started and tachycardic.
Okay, so what are your thoughts? You don't like it? That's good. You're now the PACU resident. What are your thoughts about what might be going on? This patient just had a bronch.
So multiple things could be causing it. Could be mucus plugging from the bronch. It could be relative hypoxemia from the anesthetic. Are they breathing appropriately? I want to do a physical evaluation to see kind of what their breathing status is, listen to their lungs. I want to place oxygen on them simultaneously to try to see if I can change their their respiratory status.
Yeah. All right. That's fair. Dr. Pagrazinski says iatrogenic pneumo. That's a good thought. What about other things for post-operative dyspnea? Oops. Sorry. Poor slide operations. Anybody have any comments on what might be driving post-op dyspnea? It can be in this patient or in patients in general. Let's see. We should pick on someone for that. Let's see. Dr. Patel. Dr. Rushi Patel, can you give us a quick differential for post-op dyspnea?
Can you hear me?
Yep.
All right. So I think I missed some of it for this patient, but I heard some of the things, possibly incomplete reversal of neuromuscular blockade. I don't know if that was said. Excessive opiate use. Other than that, COPD exacerbation or some form of bronchospasm. I don't know what else was said, but those are some ones that come to.
That's pretty good. This is what we came up with here. So lots of different things that can be going on here. Residual blockade was mentioned by Dr. Carter in the chat. Thanks, Willie. You're up next, by the way, for questions, so beware. Frailty. This patient's old, has cancer. COPD exacerbation, asthma. We had some wheezing pre-op. Airway obstruction, either from secretions or bleeding or something else. Pulmonary embolism, fluid overload. So there's a lot of things that can be going on. So what about the agitation? Dr. Carter, do you want to comment on what might be driving post-op agitation in patients? And it can be this patient or patients in general.
I don't know if she had a history of some anxiety or depression, but I've seen patients who do have a history of that. Sometimes when they wake up from emergence and stuff, they're a little bit more agitated and anxious.
That's fair. Anything else?
If she's hypoxic and maybe hypercapnic, it can be causing maybe some.
Yep, hypoxia, so respiratory distress, that's a big driver. Let's see, anything else? Anyone?
Emergence delirium.
Emergence delirium, right. Residual anesthetic drugs, that's a great one. So there's also a lot of things that could be going on here, right? So medication effect, emergence delirium, the hypotension and the hypoxia, so stages of early shock can be doing it. Now, this patient's hypertensive, so that's not what's going on. Pain is one of the most common causes. Post-op nausea and vomiting can cause people to be pretty agitated. And then serious problems, heart attack, stroke. Urinary retention is something I feel like we don't usually think about, but it's usually our surgical or nursing colleagues that come up with that on the differential, but that's a big problem as well. All right.
But so patient comes in and actually the anesthesia person's holding an ambu bag to their face in two hands and giving some positive pressure help because they're struggling as much. The oxygen's all the way up on it. So PACU resident listens and they hear breath sounds with those assisted breaths. Patient, like we said, is anxious and is in distress. Not the like, oh, they look like they're uncomfortable. They are struggling hard. And when we check and see how air's moving without the ambu, we can't really identify any breathing.
Dr. Carr, Dr. Rootveer Carr, do you want to comment on what might be going on here?
I think that can be because of some obstruction going on in the respiratory passage because patient is anxious and the air entry is poor.
Great. So so some sort of mechanical obstruction with their breathing. That's definitely fair. No stridor is noted. Dr. Carter just asked about that. Go to the next slide here. So yes, the next one, this is maybe for a senior. What are going to be your first steps?
Dr. Kaplis. I
Can
see.
you hear me?
Yep. Awesome.
Yep. Okay. Sorry. So if we're unable to move air, I think I missed the first part. Were we able to actually move air when we were ambu bagging?
Yes.
Okay, so I would call for an extra set of hands and also call for respiratory therapy in the PACU to bring the V60 CPAP, because this patient's certainly going to need additional respiratory support, and also make sure I have equipment to have a more secure airway in case they decompensate further. I would also administer, and I didn't hear what they were reversed with, but make sure they were fully reversed with 2-Gamma-Dex. And also consider administering Narcan if I thought they were over narcotized and that was obstructing further respiratory efforts. That's where I'd start, at least from what I heard.
Okay.
Reasonable.
Yeah.
That's reasonable. So the PACU resident that was not hypothetical had a similar thought, grabbed some Sugaminex, started giving it at about 100 milligram increments. The patient did become less anxious.
Yeah.
And then there was some improvement in respiratory status.
Specifically, they didn't need that assistance anymore from the ambu bag. They can move air, and much like we do in our pediatric rotations, you can notice that air's moving because you put your hand in front of their mouth, and it feels normal. It doesn't feel very light. So they're moving air now. But your sats are still in the 80s, but they're not going down anymore. So Dr. Gonzalez, what do you want to do now?
So you gave this to Gammadex. So what are we asking at this point? Sorry, I'm just getting into the hospital.
That's okay. Yeah, so the patient was hypoxic and struggling.
Yep.
Gave them some additional reversal, and doesn't look like they're struggling anymore, but they're still hypoxic, and they came in on room air, satting well. So this is a change. What do you want to do?
So they're so they're still hypoxic. I would and they're extubated at this point, or
Yeah. Extubated.
So I would consider reintubation as well, just to attenuate any hypoxia. I would do maybe some imaging as well to kind of figure out what's going on.
What kind of imaging do you want to do?
We could start off with the chest X-ray.
Okay.
Because that's really quick.
Yeah, it's going to be 5 minutes to 10 minutes for portable X-ray to get here. What else can you do?
We could do an ultrasound as well to kind of see if we can see signs of a pneumothorax or something like that.
Okay. All right. Anything else?
As well.
It's always okay to say no.
Yeah, I'm not sure of anything else. I would be concerned about just reintubating this patient.
All right. So now what? Repeated a physical exam. Patient can phonate now. But you listen, and there's only you have unilateral breath sounds. You really don't hear much on the right side. So we kind of talked, and let's do some lung ultrasound. So who do we want to ask? Dr. Ricci, do you know anything about lung POCUS or lung ultrasounds?
How would you do this in the PACU, Alex?
I don't remember much about lung POCUS.
Okay.
Okay. Good thing we're going to cover it right now.
Yeah.
Does anybody want to weigh in on how you might do a lung POCUS in the ultrasound in the PACU?
So the difficulty with doing it in the PACU is we do not have, at least last time I was in there, easy access to phasor array probes. The linear probe to look for lung sliding throughout the lung fields is also possible, but I'm less familiar with that or was not trained on that. But we basically look for sliding of the pleura, and you can put the ultrasound on M mode. Basically, if you have the seashore sign, which I'm guessing will be a picture to follow of that, that means that there is positive sliding of the visceral and parietal pleura. you do not have a pneumothorax in that area or a tension pneumothorax in that area. And if there is the barcode sign indicating no movement between those layers, then you have a pneumothorax at that level.
Perfect. So the thing to clarify is that you can do a lung exam with a phased array, with a linear, with a curvilinear. You can do it with any probe you have, as long as you can get the depth that you need. And so this is where you're putting it. You're putting it between the second and third ribs and the intercostal space on the mid-clavicular line with the patient supine. And this would be where you're looking for the pneumothorax. And if we go ahead and go, Isam, I saw that you were on here. Since you're on RAPS, and this is a view that is very similar to what you would see for a PIF block, could you tell me what the blue arrows are pointing to?
Ribs.
Okay, and then what is the yellow arrow pointing to?
That would be the pleura.
All right, and then what is the dotted red circle?
Let me zoom in.
It's an area.
It's, yeah.
There's nothing hidden in the mist.
Oh, just the lung.
Exactly. Yep. So
Okay.
your major landmarks to look for are in between the ribs, which are going to cause the shadow, the hyperechoic pleural line, and then the stuff underneath it, which is, if it looks like tissue, it is lung, and if it's empty, well, you got a problem. So this is what M-mode looks like. You're imaging over this dotted or this line, and the bottom area is over time. So this is the tracing that you get. And like Dr. Kaplan said, seashore sign is the sandy thing that's normal at that specific location of where the ultrasound is. The barcode, or some people document it as stratosphere sign, that's where you're not having lung sliding. That could be possible pneumothorax. But if someone's had, say, a pleurodesis or a pneumonectomy, or has had an empyema and has scarring, there's a lot of times where you may not get lung sliding and it's not because of a pneumothorax. But if you see a lung point, and we'll go look at that image again, where you go from this grainy to the lines, that is where the lung is no longer moving against the pleura, and that confirms the presence of a pneumothorax. That is 100% specific. So in the labeled view here, you can see at the bottom, we've labeled the seashore sign, the barcode sign, and where you get that abrupt transition, that is the lung point. So on this person's image, this was the exact point of the pneumothorax coming into view. All right. So since someone said get a chest x-ray, we got this beautiful chest x-ray. And you can see, just for the interest of time, it is kind of a no-brainer when you look at it on the right side. The lung, it has space around it.
Can everyone see that pretty clearly? All across the right side, right lateral, right upper, right lower, there's a large pneumothorax. So now what? Dr. Chalewa, what are you going to do about this patient's pneumothorax in the PACU?
You can do like a needle decompression.
Anna, I can't hear you. I'm so sorry. I can tell you're talking, but I don't know if your microphone's covered, maybe. Try one more time.
Hello?
Yep, we gotcha.
Okay, sorry, I'm driving. You can do like a needle thoracotomy if you don't have time, needle decompression.
Oh, okay.
But I'm assuming you have time, so you can just insert in chest tube.
That's very
excellent.
Excellent.
Surgery.
Yep, and you know, in the PACU, there's probably someone surgically capable, relatively handy.
Yeah. So in this patient, a pigtail catheter was put in place. You can tell it's a pigtail because it's got the curly Q at the end, and the lung re-expanded, and they did pretty darn good.
This is beautiful, and that's wonderful. So
then, do you guys, so there was some empiric things that were done here. Dr. Hinton, do you think that the patient was still weak? They got neoglyco in the procedure area. Do you think they were still weak?
Based upon their improvement from the Sugamidex after it was given, I do think they were still weak.
Okay. Is there a way that you could have been able to tell other than the physical exam that we did?
You could recheck with a twitch monitor in the PACU. I don't know if those are available in there, but you could recheck with that.
Okay. Yeah, exactly. Yep. Do you think that given the Sugamidex was reasonable?
We think it was
But yes, I do think it is.
Yeah, because one of the indications we have here is patients at risk for intubation, reintubation. So giving empiric Sugamidex to avoid an intubation, it matches with Freidert's policies. So, all right. And then
this is just sort of a catch-all. Does anybody have any other thoughts on what we might have done in the PACU or anything we could have missed?
This is Cindy Lee, and I have my hand raised, but you might not see it on your screen.
we see
here.
it.
We see it now.
I just have to make a comment about adequacy of reversal and the import of monitoring. I will put in the chat a review from BJA in 2014 looking at awareness under anesthesia during induction and during emergence from anesthesia, and how that is one associated with residual paralysis. No patient should receive a neuromuscular blocking agent unless their twitch is being documented. And at the end of an anesthetic prior to extubation, we need to document that their trainer-4 ratio is back to 0.9. I understand the use of Sugamidex in a patient who looks weak, but it is really not a test of residual weakness. We have the monitoring available to document it, and medication should only be administered when indicated.
Thank you. Precision in what we do. I appreciate that. I was hoping someone would talk about that. All right. So we've got just a little bit. So if the desaturation occurred in the OR, I just want to run over this. We've got about 10 minutes, so I'm going to kind of fast jam this because it's a little bit, we're going to run over otherwise. So the other question that comes up is, what if this patient had been in the operating room where this pneumothorax had manifested prior to extubation? So in the operating room, we often have a differential of hypoxia that's relatively complex. This branches like a tree. You can, you have all these common things: hypoventilation, VQ mismatch, your FiO2 is low, your, MH, metabolic demand, cardiac or pulmonary disease, and then you can have artifact, the pulse ox is knocked off the finger. And all of those can have different sub causes within them. So this is a broad differential when you have hypoxia in the OR. And we just want to talk through this diagnostic step. All of these things are things we do every day. And they're kind of a wall of text because there's really no set order that is necessarily better than, better to consistently do on every patient. And you're going to react in an intelligent way for every case in a kind of a tailored way to what you
Based
have.
on what's higher on the differential.
Correct. And you're going to do that in real time. So all of these things are things you're going to check when hypoxia is there. So if you're in the OR and your patient's hypoxic, these are things we might do. And this was intended for the CA1s, but we've used most of the time. So you guys can review these slides later. And then final causes after you've done a basic workup is occasionally we do need to consider terminating surgery if the hypoxia is refractory. So in this case, and this is the point I want to hammer home, what was the most likely cause of this patient's pneumothorax? Dr. Nye, I saw you just popped in. What's the patient had a bronch and was hypoxic in the PACU? What is the most likely cause of pneumothorax in this patient? Okay, time's up because we're low on time. So it was probably an iatrogenic injury from the bronch. That's the most likely cause. However, we also note that the patient was getting ambued on the way over, probably by a stressed resident. There is no pressure limitation to an ambu bag. You have to pop the plastic before it will stop giving pressure. So it is entirely possible that the patient was weak and you had an overzealous team hyper bagging them, and the pneumothorax was caused by the bagging. We don't know. It's probably the bronch, but just food for thought. In the OR, these are the most common causes. And then we'll skip the fun comic. You guys can look at that in the slides. And the thing that I really want to talk about is this. If your patient's intubated, the risk of complications from the pneumothorax, catastrophic complications, is extremely high. In fact, it's so high that we wanted to take a minute and review it on this article. With positive pressure ventilation, the risk of hypoxia, hypotension, and cardiac arrest is much higher. And when we looked up the magnitude of the effect, this is what we got. I don't know if you guys can see that. So if somebody's extubated, they have about a 50% risk of hypoxia with a pneumothorax, and we see small ones that are inconsequential all the time. If they're intubated, 92% of patients get hypoxic, which tells you that they're rapidly progressing towards tension pneumothoraces. And with unassisted breathing, this nice lady in the PACU, she's does have a risk of cardiac arrest and hypotension and all of that. If she were still intubated, that risk, the odds ratio, not the percentage, but the odds ratio is 12.6. So she's 1,200% times, 1,200% more likely to have hypotension and almost 20 times more likely to arrest, the odds ratio of 17.7. So having a patient who's intubated, who's got a pneumothorax or a suspected pneumothorax, is a high level emergency that almost, I don't want to say almost certainly, but has a very high risk of progressing towards catastrophic collapse if we don't address that early. Obviously, these need decompression. And then this is the last teaching point we wanted to talk about in the last couple minutes, and then we can open it up to questions. But the classic approach for a needle thoracostomy is, and we learned this in medical school, the second intercostal space in the midclavicular line, which is nicely mapped out. If you Google it, you can see where this goes. And what you can see is what you're trying to do is catch the rib cage sort of as it dives backwards here at the midclavicular line. What you're trying to avoid is all this high quality real estate of the heart that sits in the anterior chest. I have seen surgeons in pediatric patients fail to achieve an intrathoracic placement of a needle with this approach. So in reviewing the literature, we did find that there's an updated recommended approach where they actually recommend the fourth or fifth intercostal space in the mid or anterior axillary line, so over where you would place a chest tube. So this is Rebel EM, and this is fantastic anatomy. I hope everyone's okay with Arnold here, but this is the classic position, the A, and you can see, and we picked this because it really, I'm going to show a CT scan here that's not Arnold's, but you'll get what I'm talking about. And then, so this is the classic position over here at A, and then they looked in this one study at both positions B and C, so the mid and the anterior axillary line, and what they found is that there were some problems with this point A. So you can see over here in the CT scan, this is a muscular, young male who's got a lot of pectoral tissue, and you can see how deep that is, or can potentially be even close to the sternum to breach that with, what we would usually grab as a long IV needle. So the long IV needle may not make it if they have significant breast tissue, if they're obese, if they're muscular. There's a lot of reasons why this may be more difficult to even achieve. And then, here we go. This other point is, again, the heart sits right there if you go a little too low. And so you can see that at this level of the CT scan, if you enter, over here, there is no lung to hit. You go straight from the chest wall right into the pericardial space. And we've had cases of that in the ICU. So going laterally here at this point B or point C, what they found is, and this is the results from one of those studies, at point B, it was approximately equal. There was a little bit higher chance of success. But if you go anterior, so right under the pectoral muscle here, they found a much higher chance of success, which is represented here as a lower chance of failure at 13% versus, 30 or 40% for these other sites. So this is different than what we're classically taught. This is where the thoracic surgeons recommend doing this. I've had Dr. Linsky recommend that. He said, don't bother with that. Go where you would place a chest tube. And so I just wanted to make everyone aware of that. This is where we place the chest tubes often in the ICU. And the other thing I will point out is you are above the nipple line when you're doing this. So it's very high up on the chest wall. It's higher than you think. If you go where your intuition tells you, you may end up in the liver. So up right under the pec, right above the nipple, will give you great access to the chest wall. In a pinch, you can place a needle there. There's a low risk of puncturing anything important because the heart's over there in the center. So I just recommend everyone be aware of this and be thoughtful about it. And that's our final teaching point. All right, so rest of the case is too long. What questions does anyone have? Anybody have questions or comments on our last couple minutes?
I have a question about, so you empirically gave Sugamidex. At that point, if you do have to reintubate, you cannot use rocuronium then because it will be ineffective since they have probably an excess of Sugamidex, correct?
Yeah.
Thanks.
So then the question I'll pose it back to you is, do you need a paralytic to intubate?
No, but it makes it a lot easier.
Agreed. Agreed.
Correct answer. And you can give succinylcholine still.
Yeah. There was no contraindication for this particular patient.
Good question. Anybody else?
All right.
I have one really, I just have one really quick comment. Can I throw in one at the end?
Yes.
Okay, so I think this was a fantastic case to describe. I think, the comments that you guys made about ASA physical status was really right on, just in terms of patients who haven't seen the, who do a kind of a half pre-op and then they always assign an ASA status at the beginning of the case, and they haven't even seen the patient or talked to the patient because that's where the nuance occurs. I think that's a common problem that we have within the organization. But my other comment was just from a system standpoint, and we could expound on this in another conference, but reintubation, or what's called post-op respiratory failure, is something that is also tracked for the hospital. We review all of them in our department, thankfully, because otherwise they'd go to the coders and to somebody else. But there's some things that are exclusions, like somebody who has lung surgery, esophageal surgery, and a number of comorbidities that will exclude them. But for pulmonary surgery or a bronch, it's probably going to be excluded as a post-op respiratory failure. But just so that you're all aware, one of the things that I've heard commonly people mention, like, let's do a trial of extubation. I want you to think about that before you choose to go that route with some patients, because having to reintubate somebody because you're thinking, well, maybe they'll fly and maybe they won't, may end up in the end not only increasing the morbidity for the patient, but it also affects us as a system. So I just need to bring that up. There's these kind of that's considered a patient safety indicator, and it really is something that's highlighted quite a bit in all the rating systems. So especially CMS. So anyway, just wanted to add that in.
Thank you.
Yeah, thanks.
Yeah, I've heard that term in other ICUs. That's a common, I feel like a trial of extubation is basically, well, I don't know what's going to happen and I'm not smart enough or don't care enough to try to figure it out. So I'm just going to see. And I agree completely that that's sloppy care and it's substandard care. Our reintubation rate in the CVICU is much lower than the literature suggests it should be. And part of that is our patient population. And part of that is because we're anesthesiologists and we don't accept the idea that a reintubation is an acceptable risk for most of these patients, and that definitely applies to the operating room as well. So if you're not sure what's going to happen, you don't have to take the tube out. There's no rule that says you have to do that. And the charge nurse who's giving you the eye of we have a case to go in 15 minutes, you can ignore her or him. Anyway, I really appreciate that point, Kathy. We are over time by 1 minute. Dr. Dolinsky wants to point out that a transbronchial biopsy is a point of risk for a pneumothorax, and I agree completely. So bronchs are not without risk. And thank you all for coming this morning. We had a lot of fun.
All right, take care, everyone.
Thank you, guys.
Thank you.